Thank you, and welcome everyone. I am a part of the American Journal of Surgery STARS committee. Our overall mission is to make academic surgery more accessible. This virtual seminar series is entitled Roses and Thorns of Academic Surgery. It's an exciting time to be in academic surgery, but sometimes it can be daunting to reach our career goals. And so the purpose of the seminar series is to learn from leaders in academic surgery, hear about their successes, but also their failures and challenges that they've overcome throughout their career trajectory. Hearing this can be reassuring for trainees that are passionate about academic surgery. Additionally, this interactive session serves as a platform to connect with a leader in academic surgery. It's an opportunity that's not always feasible during a national meeting. And so we are incredibly excited to be hosting the esteemed academic leader and surgeon, Dr. Andrew Ibrahim. Just quickly, I'll go over his training pedigree, which he let me know that he's going to talk about. He received his medical degree at Case Western University and a Master's of Science at the University of Michigan. He has completed two fellowships in policy and outcomes research at Johns Hopkins and the Robert Wood Johnson and was a Robert Wood Johnson Clinical Scholar at the University of Michigan. He began general surgery residency at University Hospitals of Cleveland, and he actually transferred to Michigan Medicine General Surgery Residency, which he completed in 2020. He does have a number of leadership positions. He is the Maud T. Lane Research Professor at Michigan. He's the co-director of what's known as CHOP, the Center for Healthcare Outcomes and Policy at the University of Michigan. He is assistant professor of Veterans Administration and Architecture and Urban Planning program, and he's the director of the Health and Design Fellowship. Um, Dr. Ibrahim is making important contributions to health policy and outcomes research at the interface of costs, quality, and redesigning delivery systems of care. He sits on the editorial board of the Annals of Surgery and the JAMA Network and has presented at several national and international professional conferences. And it is my understanding that he is the founder of the visual abstract. That's something that at STARS we've fully embraced. So excited to hear from you, Dr. Ibrahim. You can take it away.
Awesome. Well, thanks for letting me hang out, especially after you guys had like a pretty esteemed crew with Herb Chen, Clecia Clark, Khan, Martin. I mean, these are people who are giants in our field that I look up to a ton. I have like a lot of fancy titles that I won't flex on and spend too much time, but I want to upfront tell you that everyone who has roses has gone through a lot of thorns, and I'll hopefully try to tell you a little bit more about the thorns, but hopefully give you a framework. And I think I often get asked like, hey, how did you know you're going to be working in a global architecture firm doing surgery and like getting R01s in health policy? Like no one knew that, right? Like don't let anyone fool you and be like, when I was 12 years old, man, it was a crystal clear thing. I knew it was going to happen. That's quite never the case. So this talk's affectionately titled Moving Forward When You Don't Know Where You're Going. I get to do some pretty cool stuff. So I'm a general surgeon. I'm in the OR every Monday, clinic every Tuesday. Every fifth week, I'm on call for whatever comes in. I say that's like the core of my identity. I'm a formally trained health services researcher. I get to run this group called CHOP. We're a busy health services research group. We put out a little over 500 papers a year and about $35 million in active funding and 13 faculty who are R01 funded. So we're busy, and it's super humbling to get to lead a group that does this much work. And before all that, I studied architecture. I did my foundation coursework at the Bartlett in London, and spent 6 years as a senior principal at HOK. Senior principal is probably the equivalent of like a full professor, and HOK is one of the biggest firms in the world. So if you've ever been to Apple's headquarters, Mercedes-Benz Stadium in Atlanta, LaGuardia's new terminal, all of those are HOK. So it's pretty unusual. And I'd say like, because I have this kind of weird combination of things, I get two types of students in my office. One is the coming in hot crew that is, I already wrote their papers, AOA, Rhodes Scholar, and I'm kind of like, who's interviewing who here? Because it's kind of like, Jesus, that's a long list. And then I get this group too, who like filled their boards, haven't written anything. They're like wondering, like, I mean, I might be in the wrong place altogether at this point. And it might surprise you to know, like, that was me. Like when I was a med student, like that was my portfolio. I just failed my boards. I didn't really have like a research story. And I was kind of like, man, what did I get myself into? I thought I had a clear vision of what I wanted to do and felt like the rug got pulled out from under me. And on a kind of chance encounter, I met a guy named Justin Dimmick. At the time, he was an assistant professor. And I was a med student who'd failed boards. It was not looking promising to match. And I actually didn't match. I was an unmatched prelim. Emailed a bunch of surgeons and said, you know, I have this vision. It's a little outside the box of what I want to do. And I think it could help our field. I just feeling pretty not even on the bottom rung of the ladder. So Dr. Dimmick introduced me to all these groups, like the Association for Academic Surgery, Surgical Outcomes Club, Academy Health Sages. And I got to meet a lot of these people. Some of you may recognize them. They're all giants in our field. Eugene Kim, Chief of Pediatric Surgery in California. John Berkmeyer, probably like the modern day founder of like outcomes research. Rebecca Minter, the chair at Wisconsin. Dori Segev, probably like the most funded investigator in our history who developed the whole algorithm for how we match organs in the United States. Do you know what all of them had in common? None of them matched into residency. All those people on match day were sitting there with nowhere to go. And it's kind of wild to think that there's a whole cohort of people who at like this pinnacle moment where you're sort of like, this is really like the defining trajectory of like where you match, where you train, where your career is going to go. Actually had their feet, the rug pulled out from under them too. And so it gave me some peace and I was like, wow, like I think maybe I could do this after all. And so what I want to do is from that, I kind of learned a ton about finding your way, especially when the model's not clear and things aren't, the breaks aren't really going your way. And I'll tell you, even though most of you may be at your, say, medical student or resident level, I promise you that this challenge or question of like, what am I doing? Where am I supposed to be going? Am I getting there? Follows you at every stage. It happens to assistant professors, happens to associate professors who are tenured, happens to full professors, and it happens to chairs. It happens at every level. So I'll tell you about these three challenges and I'll hopefully give you a way to like address them and think about it from my own story. And the first is, how do you move forward when you don't know where you're going? A lot of momentum, a lot of energy. I just want to do something, man. But I don't exactly know what. Just put me in, coach. The next is like, how do you go faster? Like once you get a taste of the thing that you're supposed to be doing, you know, and you're like, and then you're just frustrated because you're like, but it's just taken me so long to get momentum in this thing. And then finally, you get momentum, you're doing it, and you're like, is anyone going to read this paper? Like, is this even having any impact? Like, is this even moving the topic forward? So I'll hopefully try to give you hacks for all of them. And then you'll never have existential angst in your career ever again. Kidding. In retrospect, if I was like thinking about myself as like a student, I was like, man, if I could only find a mentor that was an R01 funded surgeon scientist with a multidisciplinary fellowship while running a global architecture firm, like obviously that doesn't exist, but that's kind of like the model that so many of us are used to, that if we want to become something, we think we need like the exact prototype to lean into. But I got close and I met this guy named Justin Dimmick. I went on this 2-hour drive in the middle of a February winter from Ohio to Cleveland. Does anyone know what MapQuest is? It's kind of like the OG version of Google Maps before like Google Maps existed. And you would like print it out on a printer and you would put it in your car and you would turn the pages as you like moved along the route. I know, it's crazy. It's like record players. So that's when I first met Justin. It's over almost like 12 years ago. And I told him this grand vision I had about health in the built environment And like, man, I like trained in architecture. I love outcomes research. I want to bring that to surgery. And he very politely was like, hey man, I'm not an architect. And it was kind of like the same way, like if you went to like a liver transplant surgeon and said you wanted to get really good at inguinal hernias, like could they do it? Maybe, but you probably want to learn like liver surgery from those people. And if you want to learn hernia surgery, you go to like one of the MIS people. It was like kind of like pretty snarky, but I didn't know that. So I thought I could win him over. So this was Dr. Dimmick's desk at CHOP, which he was director at the time. And I brought a like fully written paper, like my first day. And I'm like, I know this guy told me he's not an architect, but if I just show him what the magic looks like, he'll know. And he very politely said, why don't we just like leave this over here? And the next week I came in and it was just like a little further over. And then finally it was like literally almost about to fall off into the trash can. And it ultimately did. And he goes, hey man, you can just let it go. It's okay. And what he said there was actually more profound. He said, I actually need to teach you how to write a high impact paper. Like it's very unusual to find a mentor who says, hey, I'm not taking any shortcuts here. I know you already wrote this thing that maybe could get into a so-so journal, maybe not, but I want to teach you how to do it like the right way. And that means we got to start from like nothing. So I'd say like on the start, if you like stop the story there, you'd be like, geez, Andrew, doesn't really sound like you're finding your way so far. I mean, you kind of like had this story, you've kind of like filled your board, you're kind of floating a little, and now you've like found this mentor who literally threw your first paper away. But he said, I do know how to evaluate hospital quality, and I do know how to geospatially map where hospitals are located. So this is a map of rural hospital closures in the United States in like the 1990s. And because it was so dramatic, Medicare came out with this huge payment policy to say that if you were a hospital less than 25 beds, more than 35 miles away from another hospital, we're going to give you a critical access hospital designation that makes you eligible for more money so you can stay open. At the time, it was like $9 billion annually. And people are kind of fussy about like, why are we giving so much money to these hospitals that are geographically located in weird places? I knew the importance of it because I did like architecture and urban planning. Like I understood the assignment, but no, there wasn't enough evidence to understand it. So I looked at 4 common operations that we do all the time: appies, choles, colectomies, hernias, and compared them at these small rural hospitals compared to like everybody else. And sure enough, these rural hospitals actually do pretty well. For common general surgery, they have like the same or better outcomes. Isn't that wild? Like take that in. It's like kind of counterintuitive, like David beats Goliath kind of thing. But it was a big payment policy, and most policymakers wanted to know, well, how much is that costing us? If we're subsidizing this thing out the wazoo, like why is it worth it? Is it worth the $9 billion annually? It turns out these hospitals actually cost less. You don't have to get too much into the different math here, but they actually provide the same or better care for less money because they have less overhead and don't use as much stuff. That paper was published in JAMA, and in their first 19,000 publications, it was the 49th most shared paper in their journal. That whole project took me like a year. That whole 5 slides took a year because I literally had to write like sentence by sentence before I was allowed to move forward. And it changed my life, but not for the reason you think. Initially, I thought it changed my life because, Jesus, I just published in one of our best journals. But it changed my life for totally different reasons. I learned all these skills. I learned how to code data. I learned how to work in Medicare claims. I learned how to compare quality. I learned how to write for generalist audiences. Have you guys ever tried to take like anything that we do in surgery and explain it to someone who's like not even in medicine? They're like, wait a minute. So you blow up someone's belly with air and then stick like a hollow pencil into their side and then jam instruments down it to take out like an organ? I'm like, that's exactly what we do, but we call it other stuff. Like we sound kind of nuts until you find a way to like talk about our work to the lay public. The meme reference there, by the way, is a movie called Grease. Probably also too young for the reference, but a guy named John Travolta. Anyway, so I had these skills, which was cool. Like I knew how to like do stuff. And you might say, like, Andrew, like that's nice, but geez, we're pretty far away from this whole architecture vision that you talked about. Has anyone in the room ever designed an operating room? No people? Amazing. All right. Does anyone know? I was like a little sarcastic. Does anyone know what this is a diagram of? Like, what are these little streamers coming out of the ceiling? You can either type it or just like blurb it out.
I want to say airflow because that's what the
It's
slide looks
totally
like it's about.
airflow. Airflow in the operating room is one of the most like sophisticated animals in the whole hospital. The way we design airflow in the hospital involves air coming out over the patient's bed after it's been filtered, and the outtake for the air is in the corners. So you create this perfect laminar flow that brings clean air in and then exits the air in a uniform pattern to maintain a sterile field over the patient. Isn't that fascinating? It's like one of the most like esoteric details that like you learn and you know it's important, but like you're kind of annoyed by it. I like to think of laminar flow in the OR as like the Krebs cycle of hospital architecture. Like definitely important. You probably should know it, but hope like no one asks you the details later. Which, by the way, 36 ATP, 38 if you count the two ADPHs. Anyway, so who cares about this, right? Like no one cares about like the Krebs cycle and this until like COVID hits. I don't know if you guys remember COVID 4 years ago, but when it hit in March, everybody's like, it's cool. This is just going to be a couple of weeks. And then it was a couple of months and everybody's like, oh, we're just going to ride it out for the summer. We'll eat outdoors all the time. And then somewhere around September, everybody was like, this is still going to happen through the winter and we have to go back indoors. So how are we going to reduce COVID transmissions indoors? I knew the answer because I learned all this esoteric stuff about how to design operating rooms to keep them sterile indoors. And I learned how to write for generalist audience. So we wrote, along with a guy named Joe Allen, we wrote about how to maximize indoor air ventilation to reduce COVID transmission. You may remember this cover of the New York Times that started to talk about how schools should open their windows to create ventilation patterns. It's based on like the same work. And then just last year, actually, the CDC adopted our recommendations of 4 air changes per hour, or like a minimum amount of air circulation to reduce indoor transmission of infection. Isn't that wild? Not that I was like banking that like, hey, there's probably going to be like a massive pandemic where people want to know about air ventilation, but building your skills that can be broad ends up serving an advantage. So my first advice to you is if you want to move forward when you don't know where you're going, just try to focus on the transferable skills. Like if someone's going to take you in their lab and teach you how to write, get really damn good at writing. If someone says like, man, I'm going to teach you how to handle this data set, just learn like the methods of the data. Just try to equip yourself with so many tools because you have no idea like what you're going to need to build in a few years. But the bigger your toolbox is and the more stuff you have with you, it'll actually keep you moving forward, even if it's not clear kind of what you want to do next. The next is going faster. Eventually, you're going to catch your little bug. If you're like Lamario, it's thoracic surgery, which is apparently like everybody wants to go into thoracic surgery all of a sudden. I'm like a little, I feel like I missed the boat. I don't get it. Like half my students want to go into thoracic surgery. Most of the residents want to do it. Maybe it's the robot. I don't know. But like once you like find your thing, you're like, how do I go faster? I feel kind of frustrated. Like I'm like not getting enough tries. It's taking me too long. Like I'm not getting there. I think there are like 2 types of people in the world. This is like literally one of my best friends who, whenever he's doing like a project, he'd be like, I'm doing 4 projects and like 6 different data sets. And I'm like, I don't know how that's possible, man. Like, that's like hard to make it that complicated. And I'm more the person who does 4 projects like in the same data set. Because what you'll learn in your journey, and this is true of research, it's true of learning a new procedure in laparoscopy and endovascular stuff, is everything has a learning curve. So in research, it's like get access to the data, you learn the variables, you clean the data, make cohorts, you do the analysis, you realize it's wrong, you have to like redo the analysis, you finally get to like tables and figures. And like for me, this was like 6 months of time in my like lab time. It's like, man, I just spent like so much time just getting this basic thing. And I don't know why, but so many of my mentees, after they get to this point, say, I think it's time to learn a whole new data set. And it takes them another 6 months before they get to their second tables and figures. And I said, why not think about all the things you learned, compound those advantages, write in the same cohorts a couple times, use the same analysis profile a couple times, and compound your advantages. So what that looked like for me, I wrote that first paper about critical access hospitals, in part because I was interested in like the geographic distribution of them. But one thing that was kind of wild about these hospitals is they were exempt from all of the payment incentives in the Affordable Care Act. So the Affordable Care Act had all these pay for performance measures, the hospital readmission reductions program that everybody wanted to evaluate. And the only group that didn't have to do those policies were these critical access hospitals. And who had spent a year learning how to code and identify critical access hospitals in claims data to compare their quality? I did. So for the next few years, I wrote about emergency surgery. I wrote about like gaming of how people bill and code. And then I wrote about estimating the cost of the policy. So all of a sudden, this like skill of finding this cohort had like multiple returns once I'd learned it. And by sticking with it, I was able to answer all these other questions that I was interested in. And if any of you go down the path of like trying to write a grant for like an R01, you have to convince people to give you like millions of dollars. They don't want to give you millions of dollars for something you don't know how to do. And they want to see like, hey, Andrew, you want millions of dollars to study Medicare payment policy? Have you ever done that before? Turns out those 4 critical access papers I just told you about that kind of came rapid fire were like the first half of my grant that I put in my first year on faculty, that got me over the hump, that got this ultimately funded early. So if you want to go faster, thinking about the time you've spent on things and like getting more return on that advantage. I love to do that with my mentees, and I try to anchor them that once they've spent the time and energy to master like a concept. So Dr. Sidra Bonner was our fellow a couple of years ago, also going into thoracic. I didn't even make that up. That was just like, it's how the slides worked out. She'll be the fellow at Stanford next year. Obsessed with neighborhood deprivation, knew the terms inside and out, the definitions, how to apply it. You look neighborhood deprivation up in Sidra Bonner, paper, 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 in part because like she wanted to compound her advantage to advance her topic. Sarah Schaefer, thankfully not going into thoracic, just to like mix it up here a little bit. She spent 2 years researching with me, and I just like love. She wrote 3 papers basically in her 2 years. First one went to JAMA, second one went to Health Affairs, and by the third one, NPR was calling her. And I just thought like she is obsessed with rural access to care. And you don't have to write 50 papers to be the expert, but if you can write 2 or 3 really high quality papers on the same theme, your mission advances a lot faster because now you've built some momentum and able to move the work forward. So if you want to go faster, compound your advantages and build some specific expertise. Finally, I think like we all care about impact. I was listening to this Simon Sinek. Do you guys know him, like the leadership guy who does all these like inspirational talks, TED Talks, whatever? He was talking about how he like was at this company and talking to like the employees, and they're like, I think we're gonna quit. He's like, what? He's like, how long have you been working here? They're like, 3 months. He's like, 3 months, you're ready to quit? They're like, yeah. He's like, why? What's up? He's like, it's not having impact. Like, And it's interesting, like we have like a very hunger, all of us, to like have impact and see impact of our work. To be honest, I think that's probably why a lot of us gravitate towards surgery, because we see like direct, tangible changes of being up all night and operating and doing things. But I want to give you maybe a different way to think about impact and how you can scale your impact as you develop your expertise to move forward. So, my vision originally was to advance, architecture and health in the built environment. But I'd built all these skills. I developed all these expertises now that were pretty transferable. So how do they go together? I ended up creating a fellowship called a Health and Design Fellowship that basically brought in architects to train in health services research, so stuff that we all do, to start more explicitly making connections between the built environment and things we can measure in our health. And so we've gotten to do it. I won't belabor too many of the projects, but if you've ever studied quality measurement in the hospital, we use a structure, process, outcome framework from this guy named Don Abedian. We started using that for like operating rooms in architecture and kind of saying like, here's how architects could use our frameworks to evaluate ORs. Mitch Mead is an architect turned medical student who was one of our health and design fellows, who basically is an open source article that any of you can read, who basically took hospital floor plans and said, here's ways to evaluate the hospital quality of design and link it into patient clinical data, to just start using the data that we all use, falls, infections, transfers, errors in the hospital, and start to think about them and where they happen in the hospital, and start using the built environment as an exposure. Adrian Diaz is one of my favorite fellows, now Sir John Fellow at Chicago. Has anybody ever read The Color of Law? Mandatory summer reading if you care about anything related to health disparities. The Color of Law is a kind of forgotten story about structural racism in the United States related to housing. So in the United States, post-World War I and II, there was way more demand for housing than houses available. And so the banks were getting kind of antsy and saying, hey, we don't know who to give loans to. Way more people want to buy houses than we have money to give out. We need some help figuring out what's a safe bet. So the United States government created something called the Homeowners Loan Corporation. And they created these maps to basically say, if it's in this green neighborhood on the map, you should definitely give them the loan. If it's red, or if it's red lined, which you may have heard, definitely don't do it. And then things in between. The primary criteria for determining the color on the map was the racial composition of the neighborhood. So if you had tons of money, great credit score, were a great person to lend to, but you were in a red line neighborhood, you wouldn't get a loan. Isn't that wild? I mean, just take that in for a minute. That's like literally like law in the United States created by the government in the 1930s to like explicitly segregate who has access to housing by race. And not only did the red line neighborhoods get disadvantaged, the green neighborhoods, to keep them, had to enforce racial covenants saying that you wouldn't sell your house to a non-white person. That was the law of the land for 30, 40 years till the Civil Rights Act in the 60s. And frankly, was still like poorly enforced until another 20 years after. So we lived for probably 50, 60 years in the United States with very explicit racism and who got housing. So Adrian Diaz was our fellow, and he said, look, there's plenty of data that says like structural disadvantage matters to your health. How much does that matter to surgical patients? And does the neighborhood you live in now matter to your outcomes after surgery? So we geospatially merged Medicare claims data, which I'd spent like that whole time obsessing about in like that first critical access paper, merged it into historical maps of redlining. And this was his paper in Annals of Surgery, which he summarized the path still haunts us. For any one of our core procedures, appies, choles, cabbage, hernias, your chance of dying in the 30 days after surgery increases in a stepwise fashion just based on the amount of historic housing structural disadvantage in your neighborhood. This is risk adjusted for your age, your comorbidities, all the things. And it stratifies that way. Isn't that wild? Like, if you were to step back a couple years ago and think like, should surgeons be at the table to talk about housing discrimination? I think most reasonable people would say like, no. And yet, all of us are going to be accountable for our outcomes after surgery. And if you want to understand why our patients are doing well or not doing well after surgery, it almost seems irresponsible to not think about the environments where they come from and where they go after surgery, including their home. So this got cited a bunch just in the first year and became one of like the landmark papers to start connecting structural housing racism to modern day outcomes. Many people initially were like, well, isn't a historic red line neighborhood just a measure of a neighborhood that's not good now? Like, aren't you just getting like surrogate measures of like things don't look good now? So this is the area deprivation index on the bottom is a modern day measure of neighborhood deprivation. And it turns out that when you compare best in across area deprivation, the green line and red line neighborhoods, red line neighborhoods still have like a full % higher mortality, even when you control for area deprivation. Isn't that crazy? Like, even if the neighborhoods look the same today, the one that's been historically discriminated against for 50 years by the law of the country is manifesting in a higher mortality rate after surgery. These questions of housing and housing quality, it's hard to move people in healthcare without talking about money. So we've spent a lot of time in our healthcare system measuring like housing instability in patients. If you've been a patient recently, I've been on that end. Our health system asks you all kinds of questions about, do you have stable housing? Do you feel comfortable paying your rent? Has your power ever been turned off? Are you unsure where you're going to sleep next month? All these questions on housing instability. And it turns out health insurers are very interested in it. Every health insurer in the United States has a housing portfolio. Now, I'm not going to make like a moral judgment about whether or not I think health insurers have like a moral compass, but it is worth thinking about. If a health insurer is doing it, there's probably money involved. And sure enough, there is. So if you look at all the people admitted to the hospital in the United States who have housing instability coded on their admission, more than half of those admissions are for mental health diagnoses. Think about things that you could potentially treat outside of the hospital and that are potentially related to having better housing conditions. Mental health fits that Venn diagram. More than half the people admitted who have a diagnosis of housing instability, their primary diagnosis is for a mental health condition. All of a sudden, you can start to see the business case of why potentially investing in housing can save the healthcare system a lot of money. And all of a sudden now, all of us who mostly work as an inpatient in the hospital have a real direct connection to what's happening in our community. Dr. Bonner, a little shout out to American Journal of Surgery. You can't give a talk at AJS without citing some AJS papers. Herb Chen told me so. No, he didn't say that, but it's just a great paper. Dr. Sidra Bonner did this in surgical cohorts. So she found that when you stratify patients by the quality of the neighborhood they live in, patients in the higher deprived neighborhoods on average spent $2,000 more in their episode of care. And what was it attributable to? Readmissions and post-acute care. Literally, the idea that being at your home is not where you can get adequate care, and then you have to come back to the hospital or you have to get post-acute care, results in a larger price tag for your episode of care. So even for our surgical cohort of patients, there's actually like a real business case financial incentive for us to invest in housing as a way to like save money on surgical patients. Isn't that wild? All right, I'll bring it home. Part of this section is like, you got to collaborate with others. Like once you start building this expertise and momentum where you're like, gosh, I know something about housing, but if you want to have impact, you're going to have to build teams. So this is a team of urban planning and architecture grad students that I got to work with that Habitat for Humanity reached out to us and said, we get it. Housing matters to health. Like you don't have to convince us. But like, what do we actually do? Like we build houses all the time. We consider a number of places we're building them. Like, what do you want us to do in these places? So we took a map. This is every green dot on this map is where Habitat for Humanity was considering building a home on their docket, about the home. We geospatially merged it into the Environmental Justice Index from the CDC, which is a measure of risk factors in neighborhoods, to basically say, all right, for building in this neighborhood, air quality is like a huge challenge. Or building in this neighborhood, everybody here has poor access to things for physical activity. You can then, if you know the risk factors of where you're going to put people, could you design the homes differently to address and mitigate that? So we started building out this whole guide booklet that's free online, that for any one of these CDC measures, you could design the home differently to try to mitigate that exposure. For example, if any of you have like seasonal allergies, let me give you like a little architecture free tip. Go outside your home, look around your house, particularly around like the intake vents that come in to ventilate your house, and look at how many pollen producing plants you have. I guarantee you probably have some. And it's just wild to like think for a minute, the solution to fixing some of our asthma rates may be as simple as thinking about what are the plants literally right around our home. Like we're not asking for like huge major design changes. This is like, you're probably going to plant something anyway. Why don't you make sure it's not like an allergen producing plant that's ventilating right into your house and so on. So that's going to go to scale and will be like a book next year, hopefully, on building for health, and start to elucidate a little bit more of the science of how like the stuff we build and design every day affects our care, and will probably feature a lot of the papers I told you about. So moving forward, you don't know where you're going, focus on those transferable skills, going faster once you find the right direction, compound your advantages and build your expertise. Then when you want to scale impact, collaborate broadly with your own core of tools that'll carry the work further than you can on your own. Nothing at Michigan happens without a team. It's a packed slide, but man, these are just some of the most awesome people who've gotten to carry and lead a lot of the work. So that I'll say thank you from Chop Land, and I'll hang out to take some questions.
Awesome. That's yeah, thank you for such a fascinating talk, and giving us some pearls and talking about your exciting research that's clearly making an impact. We'll open up for questions, and I will start with one question that's kind of a broad question about advocating for policy change. How do you go about it simply, I think? And I think the context behind that question is like, how do you utilize the research you're doing to convince policymakers?
I love it. So one of the boards I sit on the board of directors for Academy Health. If you're interested in policy, I'd encourage you to look up Academy Health. Academy Health is like probably our equivalent of like the professional society that advances evidence. And I think there's probably like multiple components to it. One is you somehow want to get your finger on the pulse of like, what evidence do people even want? Like we have some ideas, like I think people want to know about like what kind of windows people should build or whatever. Like if that's not like what policymakers need, then I'm like generating a lot of evidence that's not as helpful. So one is getting your finger on the pulse. So like what evidence do people in policy need? And I would never think that any scale is too small. It literally may be like the quality officer at your hospital. Like what evidence do they need so that we get like different patient beds in that reduce the risk of falls or whatever? Like you could just talk to them and say like, what would it take for us to have a more sensible resident weekend off-hour policy? And then it goes up at like every level. And so as you find the things that are frustrating to you, you'll engage at those levels, whether it's hospitals, states, communities, all the way up to like CMS, federal policy. And you'll engage with the people. And frankly, most people, one, would like love to hear from you. Like physicians who want to engage in policy, they're like, you want to talk to us? Like there's a doctor who wants to talk to us? Like, yeah, we do. Because we often have an expertise that may be helpful to them. And so being willing to engage. And then I would say the other key maybe skill or tool to think about is like your core tools and expertise. People don't come to me like just for fun. They come to me because like I built an expertise in evaluating claims data and I built an expertise in design working at like a global firm. So think about like who are the groups you want to influence and what's like the expertise that you can bring to that conversation. So then that way you can speak with authority and know that what you're advocating for is right. What you don't want to do is go in the room and just because you're a doctor, they let you talk and you barely know this stuff. That's not going to help anyone. So you want to shore up your own expertise too.
Go ahead, Eliza.
Right, I thought you were going to say something.
No, you're
Thank
good.
you, Dr. Ibrahim. That was such an awesome talk. Thanks for talking with us about this. My question to you is, I know that you talked about you had an interest and an inkling that this is something you wanted to do, even like, early on before you started research. What if you have an interest, but you don't have like formal training in that, and this is something like non-medical, like design and architecture was one example? How would you recommend going about that, especially as a resident when you're really busy clinically and may not always have the time to pursue additional training or a
Yeah.
degree from any of us on the side?
I'll give you practical advice, but let me tell you my philosophy about it up front. And it's not totally mine, it's from my chair, Dr. Dimmick. But I think like collectively for capital S surgery to thrive, everyone's got to be at like the top of their game. Like everyone's got to be at like 105% of like what they're meant to be doing. So like if like Eliza gels like don't get you excited at night, like that's fine. And if you go to the lab just because you're like a good sport, that's cool. You maybe will get to 70 or 80% of your potential of what you're supposed to do. But you're not going to get to like 105. And my bias is like, we need everyone at 105. Like who thought visual abstracts were going to be like helpful to our field 10 years ago? I don't think anyone like called that. Who would have thought like, hey, we need a surgery resident in the lab who's formally trained in design, who's worked in studios to help us think about the visual communication of our work. Like that happened because we created an environment where people brought their talents to it. And I think the cool thing about the era of medicine we're going into is we literally need like everything. Like I met a student recently who's I think now a resident who was a pilot before they went into medicine. And he was like, I just have no idea why anyone in a health system wants to hear from a pilot. I joke you not, like the next week at our hospital, a broad announcement goes out that we're going to start using aerial drones to deliver medications to patients in their homes. And they were basically soliciting RFPs for how to design like an aerial transportation system out of our hospital to deliver medications. And I was like, don't you think you have a lot to say about that conversation? Like you intimately know the hospital and you know a lot about air transfer. You may not know all the details, but man, you sure know a lot on both sides that other people don't. And so I think that's only going to become more common. Like I think I'd be hard pressed to think of a combination of things that wouldn't become relevant because healthcare's just gotten so complicated. So one, let me say practically, it's worth spending some time to think like what's my thing? Like, yeah, you go into surgery interviews. It's all I want to do, eat, breathe, sleep. Like I sit at night and I draw brachial plexuses. I got it. Cool, sold. You're like allowed to also love other things in addition. And the way you identify those, there's a whole like philosophy of these things called red threads. Give yourself some time. It's like the gift you'll give yourself for your whole life. If you can spend like 20 minutes a week asking yourself a couple simple questions. When was the last time you did something where you totally lost track of time? Maybe it was TikTok. Maybe it was drawing something. Maybe it was coding data. Like there's a signal there. When was the last time you did something for the first time and you're like, shoot, I'm like pretty good at this. Like first time I did like a lap Coley, I was like, I don't know. I kind of just knew where the things are supposed to go. I didn't do the trainer. Just there's like some intuition about it. Those things are called red threads. And you should like listen to those in your life and kind of honor them because those are the things that you're kind of meant to be doing. If you can identify those and bring those to our field, surgery will be a ton better for it. And if you are in your lab time or in your resident time, and it's like, look, no one's designing an airport here. I got this expertise, but no one's designing that. Think about some more transferable skills. Like, what do you need to learn? Like, is it about like guideline creation? Is it about like safety protocols? Like, what is it? So I think surveying your environment for the transferable things you can learn, and then doing the hard introspective work to be like, well, what is the X factor that I know how to bring to the field potentially? Was that both obscure, philosophical, and then specific too? I'll try to ride the wave there.
No, that was awesome. Yeah, thank you for that.
Any other questions from anyone?
Are you still awake at like almost 8 o'clock? I'm like aging. I'm like, man, I'm like getting ready for like a hot chocolate in bed soon.
It's 7 o'clock Central Time.
Cheaters.
Yeah. People can feel free to ask questions in the chat too, but I'll go ahead and ask another question if no one's jumping to ask a question. So I saw that you recently published on comparing deprivation and vulnerability index tools for assessing socioeconomic status. And it's something that I've been working on a paper for using the DCI, Distress Community Index. And so what I've learned, especially with writing the discussion, is there's all these different tools.
There's like 20 more. Yeah.
Yeah, yeah. And actually I learned yeah, I think it was yesterday at like a medicine grand rounds. There's even a health capital index or something for a global perspective. So yeah, there's all these tools.
An opportunity index for pediatric,
Of
all kinds of
yeah,
stuff. Well, it's like,
yeah. So what do you think about these tools? It seems like not every tool is able to tease out differences in outcomes. And do you think we need to work towards a standardized tool, or do you think it's important to just consider the question you're asking and then determine which tool is best?
Every one of those tools has like an origin story, and you cannot consider the tool until you know the origin story. So let me like give you an example. The Social Vulnerability Index. Does anyone know why the Social Vulnerability Index was invented? Like it actually had like a real purpose. It's from the CDC for disaster hurricane relief, to basically say when a hurricane comes through, just like is happening now, Florida, Georgia, etc., we need to identify like who is the most vulnerable. Like where are the places that if they get hit by a disaster, like we got to get people there first. Like some neighborhoods where the people have like a second house up north and whatever, they don't have a very high score on the Social Vulnerability Index. Because when a storm comes, those people have an extra car and an extra house. They're going to be driving outside. So like they were trying to plan, like, we're not going to go spend all our resources to go to the places where we know people already have the means to take care of themselves. And so each of these indexes are chosen for a reason. And so as you know, with claims data, the numbers are so big, you can often get significance kind of just by chance. And so in our group, my practice is I don't really let anybody like start running data until they build their own conceptual model. So I have a wonderful resident right now who is floored with the phenomenon that there are many people who present with colon cancer with either an obstruction or like a bleed. Like colon cancer is kind of weird because it's like 5-6 year natural history. But if you never get a colonoscopy screening or you kind of ignore early symptoms, the natural history is that you obstruct and now it's like an emergency surgery. And this resident was like, how's that possible? So they built out a whole conceptual model and they said, if you really wanted to understand why somebody doesn't present until they're about to perforate, you probably have to go back about a decade and figure out what happens when they sprain their ankle. Like, do they go to their primary care doctor or do they go to like the emergency room? Or what happens when they have like a cough that won't go away? They go to their primary care doctor, they go to the emergency room. So they start building out this whole conceptual model of like behavioral patterns of accessing care. And so I think it is very valuable and fruitful as you approach your questions. Like, what do you think is actually going on here? And if you build out your model, it makes it a lot easier to choose the right index to mirror that. I have a fear that there's a non-trivial number of people who are just creating indexes to create them and throwing stuff against the wall and see what sticks kind of thing. Resist the urge. Because I'll tell you like one more global observation that I've kind of seen is people's applications for everything are getting like wild, like chart bloat, whatever you want to call it. 20 papers, 40 papers, 80 papers. It's starting to sound like monopoly money. And rather than just having like a bazillion papers that are kind of like these like quick burns, you don't really know what's under the hood. Man, if you got a handful of papers that you're like on fire about, you know that stuff cold. That's like rigorous work and it like advanced the topic. When you go to interview for jobs, residencies, whatever, people will be so much more impressed with that. And so I know it sounds a little crazy because you still got to like have some number of things, but it is not in vain to take the time to do the extra work of thinking through your conceptual model and choosing the right measure. It'll help you in the ultimate goal of getting where you want to go. Is everyone here a student or a resident or both? What's the mix?
I'm a first year medical student.
Amazing.
A
And
resident in research
you want to go
labs.
into surgery?
I'm interested in surgery, yes. I'm liking a lot of different things, so
You know, I was chair of the family medicine interest group in med school. Because I just liked being a generalist. I wanted to do a little bit of everything. And so I went to family medicine. I'm like, they literally do a little bit of everything. And then I met the inpatient equivalent, which is general surgery of like, they do a little bit of everything. And then I loved being a generalist. So I just refused to do a fellowship. So I kind of like, I went to general surgery because I like general surgery, not to do like a subspecialty of like 3 procedures. So, all right. I love that. Welcome. All right. Med student. Who else is a med student?
I'm a
Just
third year med student.
third year. Daniela. Third year.
Yes, third year.
Jen.
I'm an intern.
Oh my gosh. How are you an intern? You should be sleeping or getting yelled at or something. I don't know.
Yeah, it's a good point. I took a break from getting yelled at.
Oh my gosh, you're winning the game. Where are you an intern?
I'm at Jefferson in Philly.
Oh my gosh. There is a legend there in the emergency room named Bon Ku.
Yes,
You know Bon?
we've met in passing. I really don't think Bon knows who I am.
If you see him in the emergency room, he's probably wearing a pair of like 1992 Air Jordans. Like he's that cool.
Yeah. Yes,
Uh,
I have. That's how I recognize because I'm like, oh, these shoes.
Next time you see Bon, he's also like a very talented surfer.
Okay, nice.
And let me tell you about Bon, because this story is illustrative. Bon is this emergency medicine doctor who's always had this itch to like do a bigger thing. He ends up going to Princeton to get a master's in public policy, which wasn't actually the thing he wanted to do, but he learned like, yeah, here's how you get like a platform to talk about stuff. His real like love in his heart was design. So when COVID hit, he ended up taking these like abandoned Airstream trailers and converting them into vaccination clinics. But he kept the kitchens in them. So he'd make food for people to feed them when they came to get their COVID vaccines in like West Philly.
That's incredible.
The guy is like clearly brilliant.
Yeah,
Clearly
incredible.
creative. He is now recruited by the government to oversee like an over $100 million portfolio of investments of like healthcare innovation work. So kind of to your earlier thing, it's kind of like he started to be like honest to his like red threads and then like started like listening a little differently. Like what's the opportunity there? And there's obviously a need and he leaned into it. Cool. Chandler, med student, resident.
I'm a second year surgery resident.
Where?
UAB.
Oh my gosh. And Herb Chen lets you out. That's amazing.
I'm on ICU, so he doesn't have much of a say.
That's the right answer. I'm gonna come visit you guys in the spring. I don't remember when.
I'm excited. We'll be excited to have you.
Herb Chen made me come. He's like, Justin said you'd want to come. And I'm like, I'm there. Like when chairs talk, I have like, there's no pushback.
No.
Justina, med student, resident, both. I guess it can't be both.
Yeah, I'm a third year med student.
Oh yeah. Surgery?
Yeah, I'm interested in surgery.
I love it. Well, Mario, this is a cool crew, man.
For sure. Yeah. It's
You're all the cool
awesome
people.
Yeah.
Well, thanks for hanging out with you guys. You could be anywhere in the world, but you chose to hang out and talk about what to do if you don't know where you're going. I love that.
Indeed.
Well, let me tell you my hope for you, and then I'll hand things to Mario to close us out. If you go to the American College of Surgeons big annual meeting, it's coming up in like 2 weeks. There'll always be a session on wellness and burnout. You'll look in the back door and it'll be packed, like wall to wall. People you know, people you look up to, people who like author books that you read. And they'll be talking about like, here's how to like exit medicine and make like a whole new career for your life. And it makes me sad for a lot of reasons. One, obviously I want people to do whatever makes them happy. But what makes me sad is like, how do they get so far in life, like 20 years into their career, and wake up and be like, I hate what I do, like I want out. And if you back that up, it actually goes all the way back to where you are now. And being honest with yourself about like what you love and what you don't, and what you find valuable and meaningful. And as much as you can, weeding out the external signals and trying to be inwardly honest to yourself about like, hey man, I know people think I'm a huge nerd, but I really love crunching numbers. Like I want a job that crunches numbers. And you know, like if you don't like taking call and operating in the middle of the night, like please don't become a vascular surgeon. As cool as a carotid endarterectomy is and an EVAR is, 50% of that practice is doing emergency surgery at night. So the more you can be honest with yourself now about like the life you want, the things you care about, the work you want to do. My goal is to like never see you in the burnout session, because you're just like on fire about the thing you're doing. And you're like, I don't have time for that, man. I have like 20 things that I love doing and I get the chance to do them all the time. So I hope the world gives you guys enough space to always find that. It's getting like harder and harder. But I hope you get a chance to renew your commitment to what you actually want to do. So that 20 years from now, you're like, I still love it, man. I'm crushing.
Yeah, so thank you. Thank you, Dr. Ibrahim, for all the wisdom you're giving us, all the pearls. Yeah, it's very helpful to hear from your honesty. And so really appreciate the time. Appreciate everyone that's joined. These events, I think, are always helpful for me personally. So I hope you all are able to take something away and that they inspire you just as much as they inspire me. So thank you all. We will have another session, maybe in December, but maybe later. But definitely appreciate you for coming to hear what Dr. Ibrahim has to say about the roses and thorns of this crazy career in academic surgery. So appreciate you all and hope you all have a good night.
Well, good luck, guys. Have a good night.
Thank
Thank
you.
you.